I'm a consultant endocrinologist working at KMU Hospital and Research Center. I welcome you all for this 12th Midsummer Pakistani Endocrine Society Conference. So this is basically, the talk is on GLPs. So for this, we want to invite our chairpersons. Our first chairperson is Professor Dr. Uzma Malik. She is a consultant endocrinologist. Ma'am, you can come on the stage. You have your seat. Our second panel of expert is Professor Dr. A.H. Aamir. He is a consultant endocrinologist. He will join us soon. And our third panel of expert is Dr. Umar Yousaf Raja. I think so he will also join us soon. So we have also Dr. Salim Qureshi. If you can come on the stage to have your seat for the panel of experts. And also we have another panel of expert, that is Dr. Umar Wahab. If he is there, he can join us on the stage also. And also we have Professor Dr. Saeed Meher. So you can come on the stage, sir, to have your seat, sir. So, ladies and gentlemen, you know that obesity is a metabolic bomb. It is basically responsible for all the metabolic diseases like hypertension, diabetes, fatty liver, all the stuff. This is due to the obesity. So the talk is about the GLP receptor agonist, a pathway to the comprehensive metabolic care with the evidence. So for this, we have a renowned speaker. He is also a leader in the endocrinology. He is a professor of endocrinology in Northwest General Hospital. I want to invite Professor Dr. Arshad Hussain Saab. So you should come on the stage with a big clapping.
Bismillah ar-Rahman ar-Rahim. Thank you very much. Thanks for all of you, to all of you for coming here. So without any further delay, we'll start our talk. So before I actually present the actual slides of the study, I just want to give you a little background to the study as well. This is something quite well known to all of you, that Pakistan has one of the biggest burden of diabetes. And I think this reservoir, there are a lot of undiagnosed patients as well in pre-diabetic, which in time to come will become diabetic. And I think these are the recent statistics which I am presenting here. So 1 in 3 adults in Pakistan, previously it used to be 1 in 4, now they say 1 in 3. Every third adult actually in Pakistan is affected by diabetes. If you look at the role of semaglutide and GLP-1s in this whole scenario, so what are the unmet needs? The unmet needs usually, from the studies, what we know are, 1 in 4 patients achieve target HbA1c of 7% or less. And the adherence to the medication is a lot less. Is they say about 50%. Quality of life is also not good. More than 60% patients report poor quality of life due to fatigue, obesity, and complication of diabetes. So where does the semaglutide fits in? Is on the right side, as you can see. So the semaglutide provides you a therapeutic innovation, and giving you dual benefits like glucose control and weight control. And by doing those two, actually it lowers your CV events as well. So it gives you the benefit of protection in terms of cardiovascular events. Semaglutide, well known to you, is a human GLP-1 analog, 94% homology with a human GLP. But what we are presenting today is slightly different. So as we know, the biological production, which is the recombinant DNA technology, the semaglutide initially is a biological product, which was by the innovator. And it's a very long and lengthy process. You have to, have a gene and then, isolate it into a bacterial cell. There are different, parameters and different enzymes. And this whole process of developing one biological molecule might take up to 5 years, and in some cases up to 10 years. However, if we look at the biosynthetic peptide production, which is SPPS, that is actually solid phase peptide synthesis, it's a stepwise chemical assembly in a controlled environment. So the process is usually very simple. Those amino acids, Then, by different chemical reaction and different linker, you actually add them up, and then there's a chemical process, then you end up producing this biosynthetic peptide. How do you compare this with the recombinant DNA? So the biologicals, as you can see, it needs extensive trials required for product approval. There has to be, preclinical studies, and then clinical, then phase 1, 2, and 3 studies. For synthetic peptides, biosimilarity studies are even not required. Only safety, purity, and potency, what I have just, underlined here. This is what is needed by FDA and EMA. That all you have to do is to prove us that it is safe, is pure, and potency. Then when we talk about lot-to-lot consistency, because of the biological processes in the living cells, there are chances that, in the biological recombinant DNA, there may be some variation in lot-to-lot. However, in chemical synthesis, it ensures identical active ingredients across all the lots. Then you talk about the host cell impurities. That's what the FDA mostly actually, press you on, these impurities. So the risk of host cell impurities is there in biological. However, it is not there in the synthetic peptide because there are no host cells there. So the risk of, bacteria, yeast, and all those, impurities is actually none. Now, what does the FDA say about the biosynthetic peptide? This was the question asked from us the last time we presented this study, that, what does the FDA say? So ANDA is, abbreviated new drug application for, the newly purified synthetic peptide. This is on their website as well. So biosynthetic peptide, by FDA perspective, they defined peptide as amino acid polymers with 40 or less than 40 amino acid is actually called a peptide. So biosynthetic synthesized peptide can reference the recombinant DNA origin. You have to reference the innovator drug. And the ANDA pathway allowed in the same active ingredients. If you have the same active ingredient, then the pathway actually allows you to make one biosynthetic peptide. And comparable impurity profile, you have to show that as well. And you have to demonstrate safety, purity, and potency. And this applies to key peptide. What are other peptides which have been allowed before is actually glucagon, liraglutide, nisiretide, teriparatide, and teduglutide. And the focus is basically on impurity control and immunological risk. And so to summarize this, the advantages of synthetic peptides are identical structure to the reference biological product, no risk of host cells related impurities, and consistent product safety and efficacy. Now, our study is a real world evidence, so I just want to highlight a few facts about the real world evidence. So globally, 1,200 studies have been done on GLP-1 analogs and different analogs, including semaglutide. And real world evidence is actually taken by FDA and EMA for label expansion and HTA decisions. So even if the drug in initial trial have been done, the later on the expansion, the label expansion actually happens with the real world evidence. RCTs, as we all know, randomized controlled trial, they are, they're testing the efficacy under ideal condition. However, real world evidence is totally different. It measures the effectiveness in a real world patient, real comorbidities, adherence issues, and socioeconomic constraints. In RCT, you have no socioeconomic constraints. Policy impact. Because you produce this evidence, it gives you a value-based healthcare, which I'll be showing you from our study as well. So, it's very good for policy if you want to make policy. And, the key message is that the real-world evidence transform medicine from evidence-limited to evidence-inclusive evidence. Now, bridging the evidence gap, if you look at globally, the clinical trial, include only 2 to 3% of low middle-income countries' patients. Yet, 85% of the world population lives in low middle income countries. So in Pakistan, 70% of the health spending is out of pocket, as you all know. Ideally, it should be the GDP is 0.4% of GDP, but it should be more than 6%. So the real world evidence help us in cost effectiveness and resource allocation. Clinical practice relevance. You'll be sitting in your clinic and you're seeing the real patients. You see the adherence, the tolerability, patient-reported outcomes in real setting. And empowering local research. That's what we did as well, the local research. So this is our study, real-world evidence and the effectiveness and safety of biosynthetic semaglutide in type 2 diabetes, which is a multi-center study. These are the protocol which we got published a few months ago in Wiley, and our studies also published, and I think you'll be getting copies of the studies as well. So the study rationale, the evidence gap, as we know, that limited real-world evidences are there on the efficacy, medication adherence, and quality of life on biosynthetic semaglutide. In fact, probably none. This is probably the first study we are doing. The study rationale was to bridge the evidence gap by evaluating the biosynthetic semaglutide in real-world, non-interventional and multi-center study. So the primary objective was actually glycemic control as a change in HbA1c, and I'll be showing you the breakdown of the HbA1c. We had a lot of secondary objectives. So one was actually to break down the HbA1c into different, whether we can get a very good control. Can we bring it up to 7%? So we have actually broken it down. And also another was, a drop of 1% of HbA1c. And also we were looking at the weight loss from 3 to 5% if possible in these patients. And then we had a composite outcome, which was HbA1c of more than 1% drop, but at the same time, a weight loss of 3%. And we also included quality of life. And this is something different, but we thought we should do this. And then I actually requested to add this medication adherence. And, this was very good, for us to see, because as reported, 50% patient, have non-adherence to a medication. These are the ethical approvals. So we have national approvals. We actually got it from National Bioethics Committee before we actually moved on to the different centers. And international trial registration, we did this study with the University of Science Malaysia, and we got this trial registered in Australia and New Zealand Clinical Trial Registry, and the number is there. So the study, it was a prospective open label observational study, 30-week duration, both male and female of more than 18 years. And all patients with type 2 diabetes, at least 12 weeks prior to inclusion, if they were diagnosed with diabetes, they could be included in it. Treatment initiation and switching from one drug to the other or adding more drugs was actually at the discretion of the physician. And the semaglutide was administered subcutaneously once weekly through the pre-filled injector. Dose adjustment was again left to the physician. It was a physician decision, what dose they want their patient to be on. And there were 3 study visits, one baseline, and then the 12 weeks, and then at the end of the study. And discontinuation of any drug or semaglutide was also left at the discretion of the physician. This is the consort. As you can see, we had 437 patients screened, but only 309 assigned the consent to be enrolled in the study. Then there were further drop, and we came down to 268. So the baseline assessment was completed by 268. When we did a 3 months follow-up, there was a further drop, and it came down to 235. So 221 completed the study. And the effective analysis was done on 217 because some of the patients had missing data. And to show that yet it really represents the whole of the Pakistan, we took centers all over the Pakistan, including Azad Kashmir. So we had patients from, the capital territory, Islamabad, Umar Wahab and Umar Raja, they were looking after that. And we had Punjab, Sindh, Balochistan, KPK, and Kashmir. So before we go to preliminary results, if you look at the baseline characteristics, it's a very busy slide, but I've just, made those ones in bold. The BMI, if you look, the baseline BMI was very high in our patient, 33.71. Physical activity was very little people. 104 people out of all this study were totally sedentary. And if you look at the comorbids, I have highlighted this for you, that it's not that we took all the healthy patients. We took patients with hypertension, dyslipidemia, and cardiovascular disease as well. The HbA1c, if you look on the right there on the top, our baseline HbA1c was 9.27. If you look at the medication, so majority of the patients are on SGLT2 inhibitors, which is very good to see that, most physicians, everyone is actually following the guidelines. So almost all patients, you can say, are on SGLT2 inhibitor, a lot more on metformin, premixed insulin, sulfonylurea, some of them DPP4, basal insulin, and TCDs. Now, how do you see the change in HbA1c? If you look at the trajectory here, so the orange color is the female, and the blue is the male. And as you can see, the change in the HbA1c, the trajectory. Of course, the HbA1c was slightly higher in female initially to start with, but at the end, they both achieved the goal of bringing down the HbA1c. If you look at the bars, the first bar at the baseline, you see the purple color. So 81% patient actually had HbA1c of more than 8% at the start. But if you look at the extreme right one, the yellow one you see, so 38% actually achieved HbA1c of less than 7%, and then 37% actually achieved it between 7 to 7.9. And if you look at the change in the weight in 6 months' time, as you can see the trajectory, there was a quite significant weight loss as well. And 76%, as you can see that on the right extreme right bar, you see the blue color, dark blue color, 76.5% actually patients achieved 5% weight loss, which was, quite significant. If you look at the subgroup analysis, so we actually looked at whether patient characteristics or diseases or disease duration affects the efficacy of the semaglutide. Does it have any effect on the efficacy? So the answer is no. It was quite consistent in keeping, regardless of whether you were diabetic for 5 years, 10 years, or more than 10 years, whether you were a male or a female, and whatever was your HbA1c, the results are quite consistent. If you look at the age and gender and glycemic outcome, just to further break it down, so again, orange is the female and blue is the male. So as you can see, less than 40 year, I think female got very good control. They dropped their HbA1c by 1.94. And as you go on, and I think you can see a better effect. But I think men actually got a little better after age 60, so they got a little wiser, so I think they got it controlled. Now, if you look at the weight outcomes, so the weight outcomes are more or less similar in both of them, but I think there was slightly more weight loss in females, especially age more than 60. So BMI, yes, there was a drop in BMI of minus 2.9. So whatever their baseline BMI was, the average BMI we got it down to was minus 2.9. We also did the waist circumference ratio. And, so the waist actually dropped by minus 6.7 centimeter, which is quite significant. You see that there at the bottom there, minus 6.7 centimeter was a drop in the waist circumference. Now, this part of the slide is busy, so we'll just focus on the right side on the bar. So this is the efficacy and concomitant medication. So anyone who was taking semaglutide, they were taking obviously other medication, but these three were more significant. So sulfonylurea, those who were taking sulfonylurea had a drop of minus 1.87. Those who were taking metformin, they actually had a drop of 2. And those on SGLT2, they actually got minus 1.81 as well. But we are not talking about beyond glycemic control alone. Beyond glycemic control, there are other benefits as well. Fasting plasma glucose, as you can see, there was a drop. Diastolic blood pressure, there was significant drop in the systolic blood pressure as well. If you look at the HDL, there was a rise in HDL. There was slight rise in LDL. However, the triglyceride, there was a drop as well. Coming to the medication adherence, this was one of our favorite questions. So this pie chart shows you that about 28%, that's, around about 30% was a low adherence to the medication. And high adherence was only in 37.9, which is around about 40% people. So they took their medication, whether semaglutide or other medication, every day. And medium adherence, some of them actually missed the doses by about 33%. And again, on the right side is actually gender-wise distribution, but we'll skip that one. We'll come to the more important slides. So now these are the targets we achieved. So the BioSure study, the success rate. So here on the left, you can see these are the individual targets. So HbA1c of less than 7, about 38% patient actually achieved HbA1c of less than 7. HbA1c, a drop of 1% was actually 73.3, which is quite significant. Whatever their baseline was, they dropped it by 1 or even more than 1%. Weight loss of 5% was, this was something we weren't expecting. So weight loss of 5% and about 93%. And a weight loss of, more than 10% was also reported in 6.9% patient. If you look on the right side, the green one, these are the composite, that HbA1c and the weight. So the first one is the HbA1c without further weight gain, HbA1c of 7%, that was 38%. And those who were able to drop HbA1c to less than 7 and also lose weight of 5%, they were 36.9. We'll be comparing these figures with the other studies at the end. Then the HbA1c reduction of more than 1% and a weight loss of 5% was actually 70%, which is very, very significant. And the HbA1c of less than 7 without weight gain and without severe hypoglycemia, the last one is 38 as well. Because whenever we talk about the drug, we say efficacy and safety. So we were looking at the safety as well, which I'll be showing you the other slides. But in the last one, as you can see, there was without severe hypoglycemia, 38.2. Now, these are the patient-reported outcomes, satisfaction, and the hypoglycemia perception. So initially, when we did the questionnaire at the baseline, the score was 16.5. It has a significant rise towards the end of the study to 29.6. The total score is 36 for quality of life. And then the perceived frequency of hypo or hyper, this was according to the patient, that if they were feeling having a hypoglycemia, it dropped down from 8.5 to 5.2 at the end of the study. And this is patient well-being, quality of life improvement over 6 months. If you focus on the right one there, you see the dotted one, that is when they started. So they had mental health issue, they had emotional issues as well, social isolation, there were so many things. But when you see it actually turned around, and you can see physically functioning, they are actually have a physical role as well, and they were feeling a lot better. So this is based on the questionnaire they have filled in. Intention to treat analysis. So there were significant clinical outcomes confirmed on this study, and as you can see, the HbA1c drop was minus 1.65 and the weight reduction of minus 6.92. Now, the intention to treat trial is a statistical method in which you actually put all the patients as they are, regardless of whether they drop or they didn't drop, whether they complete the study or did not complete the study. So it does dilute your results as such, but it is to prevent the bias in the study. So the HbA1c reduction, I've already told you, is minus 1.79 in our study. Now, this bar is very complicated, but the red is actually the perceived risk of hypoglycemia. So the first one on here on the left, that is at the start of the study, regardless of what drugs they were on. So the score was quite high, about 66%, was the risk of hypoglycemia, perceived hypoglycemia. The second bar which you see is actually the end of the study. So as you can see, it dropped down to 16% from 60%. The rest of them are individually as per each drug. But as you can expect with sulfonylurea and with insulin, the risk of hypoglycemia is also very high. Now, this is very important slide, and I really want to take some time on this. And I think people do ask, and this is something not new. This is something which has been done before as well in the ABCD audit over years. They actually looked at the end of the study, not end of the study, but every 6 months to see, has this semaglutide had any impact on the number of the pills or the insulin dose of the patient. So if you look here on the left, on the first one, SGLT2 inhibitor, there was only a slight drop in this, okay? At the end of the study, there was a slight drop in the number of the pills or the dose of the SGLT2. If you look at the second one, the green one is actually, at the end of the study, at the 6 months, there was a rise in the use of metformin in these patients. But more significant is the premixed insulin. As you can see, there was a 43% drop in use of premixed insulin at the end of the study with the use of semaglutide. And the next one, you see the sulfonylurea, it dropped down to 23%. And DPP4 by 88%. And basal insulin dropped down to 88, quite significant drop. And then the last one is the TCD, it also dropped by 88%. So there was a significant drop in the number of the pills or the dosage and of the insulin and the oral medication. Adverse events were really minor. There was not much different from what the rest of the studies have reported. The most common was the GI one, and only 3 patients actually stopped it because they thought they were having more diarrhea, so they stopped it. Pancreatic, we don't know if this patient has had pancreatitis or not, but it has raised amylase and lipase and some epigastric pain, so we thought it's better to stop this drug. Retinopathy, this patient actually has had retinopathy before. So obviously, his diabetic control was not good, and so it got worse. So that was the one to stop. But the rest of them were very minor side effects. Now, this is the health utility. From the questionnaire, this is 5-dimensional health utility score. We looked at it objectively, what the patient has reported. And on the bottom here, this is when they started, and that's where actually where they are. So it got improved. The next one is the patient-reported outcomes. They thought at the start of the study how their quality of life is, and at the end of the study how they perceived how good they are and how confident they are. Quality of life adjusted for years as QALY. So simply one QALY means 1 year free of disease and full of health. That's just 1 year of quality of life. So QALY, did we achieve any QALY in this? So the answer is yes. If you look at the histogram there on the left, there is a dotted line here. So all the patients, all patients are all on the right side of the dotted line. So that means, yes, all of them got benefit. And the central, the red line there is actually the mean of the all, whatever they've got. So they got 0.10. So 0.10 in a year, but we got it in 6 months. And in statistical terms, that is quite significant improvement in quality of life. Now, from economic point of view, how do we translate? The number of pills was also good, but look at this one, Naeem. So this is very interesting. Look at the clinical effectiveness of daily dose insulin sparing. So we, on the average, reduce the dose of insulin by 8 units a day. That translates to 240 units a month. And at the end of the study, 1,446. That's equivalent to 5 pre-filled syringes, pens. So by 6 months, this is what we achieved. We not only got the glycemic control, we also lost weight as well. We reduced the amount of insulin they were using, and hence it was good for them economically as well. I think this is a little bit complex, but anything on the right which you see is the one which is variable variance, unfavorable variance, that does not support pay from the pocket, basically, So willing to pay is WTP, that's if you're willing to pay. On the left is what actually you see. But this is very good from our perspective because, from the dotted line, we are on the left. If you look at the biosynthetic semaglutide, our cost was like, say, $899, $696, that's just under $1 million for a year, okay? Is compared to the base of $1,629. And same is the quality of life we achieved in other ones. So from this study, what we have learned that, we got triple benefit from biosynthetic semaglutide. We got reduction of HbA1c of 1.82%. We got an average weight loss of 8.4. We got a drop in systolic blood pressure and diastolic blood pressure. And also the metabolic targets, we got lipid benefits as well, and hence cardiovascular risk, factor reduction. And that's not all, but if you see on the right side, the enhanced quality of life was very important. So near doubling of treatment satisfaction, as we said, from 16, it went up to 29. And 18-point jump in patient-related health. So the patient, the visual charts, which we said, those were reported by the patient, that how confident they feel at the end of the study, how good their control is. If they lost weight, the diabetic control was good, they felt better. And 0.39 improvement in health utility, that was the other parameter we checked. So the BioSure study, we can say, clinically safety we have shown you. We have shown you the economic impact of biosynthetic semaglutide and the high risk. So when you talk about the safety, the high risk hypoglycemia, there was a drop from 66 to 16. So 76% relative reduction in high risk of hypoglycemia. But at the same time, on the right side, you see there were 1,444 cumulative insulin units saved. It not at the cost of poor control, but at the cost of a good control, good glycemic control, and reduction in the amount of insulin. And also there was a reduction in the concomitant therapies, as you saw in basal insulin, premix insulin, all of them. So let's compare our study with the reference study. So the first one is SUSTAIN one, and the second one is the SURE program. So SURE was actually the same SUSTAIN study, where it was done a real world evidence. There was actually the SURE study. So if you look at on the last one, so our HbA1c was 9.2. We compare this with the other ones. Our HbA1c drop was more than the SURE study, -1, even better than the SUSTAIN study. The weight loss was -8.4, and the patient satisfaction was much better as compared to those. These are the funding organization for our studies, and these are the investigators which took part in this study. And that's my last slide, and thank you very much for listening to this.
Thank you very much, sir. It was a very nice presentation regarding the BioSure study, regarding the GLP analogs. Because of the short of time, we will just only take comments from our respected chairpersons.
After this excellent job by the lead investigator, Dr. Arshad Hussain, there is little that I have to say, but there are some points I have to make. सबसे पहले तो word of thanks to Ferozans, especially Mr. Adnan and Mr. Daud Bhatt, who in record time put this study together. It really is a pleasure to see all of you and so many old friends or young friends, and thanks to Faisal and the Pakistan Endocrine Society, आज पता चला है कि एंडोक्रीन सोसाइटी में इतने खूबसूरत पार्टिसिपेंट्स होते हैं, इसलिए उमर दोनों तरह के उमर यानी इतना रेगुलर है. I would be very interested in some comments from Najam Saab. It is difficult to keep track of Dr. Usama. I think वो पीछे बैठे हैं now with these better glasses. I can spot you. Otherwise, you would have been a blur. And I see server और आपको पता है रालपिंडी इस्लामाबाद से जो भी आए उसको जरा ज्यादा इम्पोर्टेंस आजकल देनी होती है. याद रखिए कि ऑब्जेक्टिव्स इस स्टडी के उस वक्त के थे कि हर कोई ऑब्जेक्ट करता था कि जी एफडीए अप्रूवल किधर है, ये तो सिंथेटिक ड्रग है. सो वी हैव टू रियलाइज द कंटेक्स्ट के फॉर द यानी दीज आर द फर्स्ट स्टडीज जो कि पाकिस्तानी रियल वर्ल्ड डाटा हमें दे रही है, एंड दिस इज नॉट जस्ट एक्सट्रैपोलेशन फ्रॉम द सस्टेन्ड ट्रायल्स. एफिकेसी की बात अरशद ने, एंड अ वेरी स्मार्ट अरशद हुसैन, आई नेवर कुड इमेजिन ही कैन बी सो स्मार्ट. एफिकेसी की पूरी बात हो गई, सेफ्टी की बात हो गई. अगेन थैंक्स टू डॉक्टर मुसरत बिकॉज हर सेंटर वाज वन ऑफ द सेंटर्स जिन्होंने सबसे ज़्यादा नंबर ऑफ पेशेंट्स टू दिस स्टडी किए. नाउ द 2 points I want to make is in adherence and persistence, this is where the Pakistani data is differing from the Ozempic trials settings. यहाँ पे जो discontinuation पाकिस्तान में हुई है, that is not only because of the biological or the GI effects of whatever constipation, diarrhea, hiccups, gastritis, etc. But it has also been the cost and then the early titration difficulties. इस ट्रायल के अंदर जो मीन टाइम है टू अचीव 1 मिलीग्राम डोज वो हमने कोई 3.25 महीने 3.5 महीने पे किया, विच इज स्लाइटली लॉन्गर देन दी ओज़ेम्पिक ट्रायल्स.
सर
लेकिन जब परसिस्ट कर गए तो 71% से ऊपर जो थे वो 1 मिलीग्राम पे रहे. इसका मतलब क्या है कि फर्स्ट 2-3 months ऑफ दीज GLP therapies are the most important. इसमें अगर किसी तरह we can through slow titration or whatever way through giving some prokinetic drugs etc.
Sir, we have short of time. If you can
Yeah,
simplify
I'll
it.
just sum it up. So this does not prove formal bioequivalence to Ozempic nor cardiovascular outcome. लेकिन रूटीन पाकिस्तानी प्रैक्टिस में इसने प्रूव कर दिया कि ग्लाइसेमिक वेट, tolerability and signals are similar to the established semaglutide therapy. Thank you.
Thank you for an emergency replacement instead of Aamir. So just few things I know about this study. The first thing is that it's really a good thing to see that our national companies are coming up with the real world data. And I must congratulate the Ferozans and all the team that they come with the idea that there should be a local data that we should have trust on it. We always talk about the international data and the different population groups. Then congratulations to the whole of the team, the Arshad and all the colleagues that they compiled the data and presented it very well. So I think so Dr. Salim has really elaborated that this is one of the drug that now it frequently used, very efficacious, and it really it's not only beneficial for the one just to control the diabetes, but it has got multiple effects. So I think the main thing which we were previously lacking was the cost. जो पुरानी दवाइयाँ होती थी बहुत महंगी होती थी, किसी को लिखें तो कुछ अरसे के बाद मरीज आके कहता था कि सर मैं अफोर्ड नहीं कर सकता. तो अल्हम्दुलिल्लाह और खुशी हुई कुछ दिन सुन के, सबको पता होगा कि सीमा की प्राइस और कम हो गई है, तो ये तो और भी अच्छी बात है कि आप ज़्यादा मरीजों को लिख सकेंगे. थैंक यू वेरी मच एंड कंक्लूजन अगेन.
Thank you.
Okay, Bismillahirrahmanirrahim. Thank you very much, Dr. Arshad, for such an elaborative talk on your study of BioSure. One thing I can, what I interpreted from your data that you have presented, that the standard fall of HbA1c, which the international guidelines show, is around 1.3% with semaglutide. But in your study, it showed that it fall up to 1.7%, which is over and above the international set standard. So it's something very good. The second thing is, okay, this drug was given over and above to DPP-4 inhibitors in this study as well, which showed that it might have augmented the effect of DPP-4 inhibitors as well, because I have seen some people stopping the DPP-4 inhibitors and then starting these GLP-1 analogs. Your study showed that you can give it, and it might be one of the reasons that HbA1c fall to such an extent. Number third is that it is in the last slide, which showed that it was an observational study. So a better evidence can be obtained if you can go ahead with the BioSure study, which include a randomized control trial in order to generate a high level of evidence as well. And one thing I was, these are some questions, because I have gone to the study just now, that what were the parameters of recruiting the study, whether the patient who developed retinopathy was having retinopathy previously, or he developed retinopathy de novo while he was on the semaglutide. And if we plan this randomized control trial in the form of randomized control trial, then we can reduce these confounders as well. Very well presented study. Thank you very much.
Thank you very much, ma'am. Just to guide you about the today's program, I want to clear you that at 6:53 to 7:15 there will be inauguration of the pharma industry exhibition. After that, 7:15 to 7:30 will be the Maghrib prayer break, and all of you are requested to be here at 7:30. So now I want to invite all the faculty, the chairpersons, the speakers, the organizers, and all the audience for the inauguration of the industry exhibition. Thank you very much.